Hi, I'm Dr. Verna Gibbs, and we're here at the Glendale Memorial Medical Center in Glendale, California, for our sponge accounting video, which is being sponsored by the Patient Safety First Collaborative. This is a video which will help you in your sponge management practice to prevent retained surgical sponges, which should be used in every case in which surgical sponges are used and an incision is made. As with any improvement practice, there are three components: the structural elements, the process, and the outcome. The outcome we expect is 0 retained surgical sponges if you use this practice. The structural elements then are, first you'll need to have a 2-prong IV pole. This is what we mean by 2 prongs. The IV pole has to be movable and it has to be adjustable so that circs of different heights can adjust the height to meet their needs. You have to have a rack which holds the box of blue-backed plastic sponge holders. Now, each of the racks come in different configurations. This is a single rack which is double-sided. This works very well for most operating rooms. An additional configuration is what we call a double rack, where you'll see that there are 2 spots for the holders hanging side by side. This is a double rack that is single-sided, but there are also double racks that are double-sided. Which one you use is up to the volume of sponges that are used during a case. For the purposes of this video, we're going to be using a single rack double-sided. The rack attaches to this 2-prong IV pole in a very important way. You need to have these 2 hooks at the top go over the top of the pole, and then it's screwed into place in these two screws here. Now this is where metal is going to be touching metal. So it's very important that we provide 4-point stabilization, because when there are a lot of sponges on the holders, if it gets very heavy, when the nurses who are tall, they're going to perhaps want it higher. Nurses who are short, has to be adjustable, and we want to make sure that this doesn't slide down the pole. Having said that, this is a 4-prong pole, and this isn't going to work for you. For one reason, when you have a 4-prong pole with these 2 hooks, you can't get them over the top of the IV pole. Therefore, what we see in operating rooms is where they've placed these racks in various places, usually higher up, and then this isn't going to work for you because you can't get the sponges that are the sponge holders out of the top of the box. So this is the wrong way. What you want to have is 2-prong IV pole with a rack securely affixed to the pole. So the other important structural elements are the signs. So there are 3 signs that must be up in the operating room in all rooms. The first is a rack sign, which is important because each of the box of holders, depending upon the different distributors, has instructions on how they want you to use the holders. We don't want you to use those, so we have a sign that fits very nicely inside the rack that covers the instructions and tells everybody in the operating room, here is where all the sponges, the used and unused sponges, are here in these hanging blue-backed plastic holders. The other sign that you want to have is the safety rules sign. This is the actions that should take place at the in count, where we check the sponges for packaging errors, the closing count, where we take a pause for the gauze, and that's the time for the surgeon to do a methodical wound exam. And at the final count, we call this the show me step, where all of the sponges must be in the holders. This sign has to be up in the operating room so it helps us do the right thing. The third sign, which is what we call the incorrect count checklist. Now let me mention that all of the signs should be laminated so that if there's any splashes, they can be wiped off. You can't have Scotch tape or any way that's visible for them to be affixed to the walls. The incorrect count checklist helps the team members do the right thing. The nurses, if they're missing a sponge, they tell the surgeon. The surgeon repeats the methodical wound exam. The nurses look in the holders to make sure that there's only one sponge per pocket, because it's important to remember that you must separate the sponges, because those Raytech especially have a tendency to stick together. If there's haven't been found, you call for additional help. If you still don't find the sponge after looking in the trash and the linens, you call for an x-ray. We want you to get 2 views. The radiologist should call back to the operating room and speak to the surgeon and tell the surgeon whether or not this image is negative. If you do not find the sponge and we have a negative x-ray, this is a problem. This is an incorrect final count, and this is we have to call the administration, get the patient out of the operating room, and deal with the issues of how to find the sponge after the patient is in a safer level of care. Now, the type of holder that you use is important. We call them holders. Various distributors call them counters or counter bags. They come in 3 different types. There's a white-backed holder that's only made by one distributor, so we don't necessarily need to use that. And there's also a clear-backed sponge holder, which actually has 10 pockets as well. But these are actually very dangerous, because when you put another clear holder in front of it, you can see that you can't tell which of the holders has the sponges inside of it. So this is the wrong way. We don't want you to use clear holders. What we want you to use are only blue-backed plastic sponge holders. So when the used sponges come off of the surgical field, they usually go into kick buckets or into ring stands. And what's important here is that we want the kick buckets to be lined with clear plastic bags, not with white plastic bags, because a white bag may be difficult to see an unused sponge. If you line your kick buckets with red biohazard bags, it may be difficult to see a bloody sponge. So we want the kick buckets or the ring stand lined with clear plastic bags. So it's clear plastic bags in the kick buckets, blue plastic hanging sponge holders to hold our sponges so that everybody can see them. All the operating rooms have to have a wall-mounted dry erase board. The dry erase boards have to be standardized so that the areas where we're putting the sponges or the needles are the same in all of the operating rooms. We use the dry erase boards to record the sponge, needle, and small miscellaneous item counts, but instrument counts are still kept on your count sheets. The way in which we want you to record the sponge counts are always managing in multiples of 10. So if you have 4x4 Raytech, we add 10. This is a running total superscript format. If we added 10 more, that's a superscript 10. The last number is the total number of sponges that are out. Now we know that laps come in packages of 5, but you're managing all sponges in multiples of 10. So you do not write 5 plus 5 plus 5. This is the old way in the unit of issue. We want you to keep track of the laps also in multiples of 10. We use the same standardized format. 10, if you added 10 more, 20. So in this case, at the end of the operation, we would expect to find 2 holders full of lap pads and 3 holders full of Raytech at the end of the case. Okay. So one of the things that you may be used to is what I call nursing hieroglyphics. And that is, when you were keeping track of counts on count sheets, use various types of signs and signatures. So we don't want plus signs, we don't want any equal signs, we don't want to see any cross-outs, no circles, no initials, because the counts now have to be clear and unambiguous. What we want to make sure you understand is that this is the wrong way. All procedural areas don't have to have a large dry erase board. You may have a small dry erase board, especially in a labor and delivery birthing room or in a procedural area. Nevertheless, you want to have a place where you add your sponges to the field, you count them, again in multiples of 10, and you write it on the dry erase board. Similarly, the way in which we write the counts can also have a vertical format, which is familiar to some because this is the way you learn to add. So instead of having a superscript, we have a summation line. Nevertheless, sponges are added in multiples of 10, and the last number is the total number of sponges. So at the end of this procedure, we should have 3 holders full of Raytech. Now we're going to show you how to put the sponges in the holders. Each of you should have received this 10-step nursing practice, which outlines the way, the proper and the safest way to make sure that we can account for the sponges at the end of the operation. Now, these are going to be laps. We take each lap pad, and you'll see that I'm using tomato juice and food coloring, red food coloring, which is actually very good even when you're doing your own demonstrations because it forms clots, and it makes sure that the nurses, when they're demonstrating this and practicing it, that they don't fling the blood all over the place. So the way in which you want to load the lap pads is to, I make them in an oval. You can load them in any different way that you want. You want to make sure that the blue marker faces forward. And you'll notice that I start at the bottom pocket. We start at the bottom 2 pockets, and we're loading horizontally. So the bottom pocket, horizontal. And we work our way up the holder, making sure that we separate each sponge, especially if we have laps and Raytech. We want to make sure that we don't have Raytech mixed in with the lap pads. What's important is that we don't want to see the tags dangling out of the pockets, and this is what I mean by a dangling tag, because if the sponges are very bloody, these tags will wick the blood and the blood will drip onto the floor. So we want the tags to be inside the pockets, facing forward. As we work our way up to the last pocket, you'll see the lap pads fit very nicely in the pockets. This is 10 laps, 10 pockets, no empty pockets. So now to show you what you would do for loading Raytech. This is why we have a double-sided rack. So we can put our Raytech on the same IV pole, but we want a separate holder for each type of sponge. Raytech, we want to make sure we separate them. We want the marker, the radiopaque marker, facing forward. Again, start at the bottom pocket, working horizontally, across, and up. The Raytech marker has to face forward, so we know, and this is especially important for Raytech, so we know that we have a surgical sponge and not a dressing sponge, which is the exact same size as a Raytech 4x4, but doesn't have a surgical marker. The other thing about the Raytech you want to be sure is that you separate them because they have a tendency to stick together. And you can easily have 2 Raytech in one pocket if you don't take the time to separate the sponges. So we work from the bottom horizontally to the top, 1 sponge per pocket. 10 pockets, at the end, no empty pockets. So now I'm going to show you the wrong way, which you might see your colleagues or somebody load the sponge holders. This is again with lap pads. So in this instance, you start at the bottom pocket and you're loading from the bottom up, but you're loading bottoms up vertically. And this fulfills the mantra, if you will, bottoms up. However, if you load bottoms up in this fashion, what will happen is you get to the top and most likely you will cross over and start your way coming down. And this is a problem because by the time you finish loading the holders, you will have an empty pocket down here. And we want the empty pockets, if they're going to be empty pockets, to be in these 2 upper pockets. So this is wrong. This is bottoms up, but this is bottoms up vertically. Now another wrong way, and this is actually the most common error, is the circulating nurse may start loading top down. And this is natural. This is the most natural, intuitive way to put the sponges in the holder. They start loading top down. Now this is really a problem because if you load top down horizontally or even top down vertically, you're going to have your empty pockets in the bottom. And these are a problem because you want everybody in the operating room to see if you have empty pockets. And empty pockets in the bottom pockets make it hard for your scrub or other people in the operating room to see. So these are wrong. And what's important about this is the very clear pattern recognition. If you see from a doorway, you'll see that you've got top pockets with sponges in them and lower pockets that are empty. And if you see this in your operating room, what you should do is stick your head in the door and say, this is wrong. We load bottoms up horizontally. And that's what we want to do, the right thing. Now, all of the holders have 10 pockets, but what you've been doing, what you're used to doing, is popping the center divider and variously counting these laps in units of 5. We call this a pouch, but in sponge accounting, we don't want the sponges managed in any unit but units of 10. So this is the wrong way to put the sponges in the holders. 1 sponge per pocket, 10 pockets, at the end, no empty pockets. So now we're going to work on the process, remembering that it's easy as 1, 2, 3. At the in count, what's important is that we want to check the sponges for manufacturing error. The practice is outlined on the 10-step nursing handout, where what's important is to see, separate, and say. We're going to begin with Raytex sponges, which come in packages of 10, and when they're added to the field, the scrub may. Here, he's showing me an unbanded package of sponges. This is wrong. The other wrong way is to take the sponges, break the band, and something called fanning. Now this is wrong because you can't see and separate the sponges appropriately. So an unbroken band or fanning are both the wrong way to perform an in count. The right way to do an in count is to break the band, separate the sponges, see, separate, and say.
I have
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 sponges. So you want to remember that what differentiates a surgical sponge from a dressing sponge is the presence of a radio-opaque marker. They're both the same size for a 4x4. And why this is as important is when you put your sponges in the holder, you want to make sure the radio-opaque marker faces forward, because that's what tells you that this is a radio-opaque surgical sponge and not a dressing sponge. So now we want to go on and just show you the good practice for counting in lap pads. As you know, they come in multiples of 5, but we always manage our sponges in multiples of 10. So here are 2 packages of laps, and the circ and scrub should then count these in. You must break the band, see, separate, and say.
I have
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11, count that
I
again.
think you better count this again.
All right.
I have
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So this
We
is
gotta get rid of these.
a bad pack, and the proper practice is to put them back into the manufacturer's container and to take them out of the operating room so they're not in the room to confound the counts on the rest of this case. So another important point about the counting in of the lap pads is this use of a blue marker. Many of you have an old meme that you count the blue, but that comes from an old practice of dangling the blue tags over the edge of a kit bucket where you would count the blue tags. But what's important on the in count is to separate the sponges. And you don't want to just count the blue, you want to touch and separate the white. 1, 2, 3, 4, 5, and if you don't separate them, you'll see here there were 6. And in this particular package, it actually turns out that you have 5 blue markers, but 6 sponges. So you want to make sure, this is a defective pack, this is a manufacturing error, that you don't count the blue. You separate the white, and that way you'll be sure that we only work in multiples of 10. Many of you may have surgeons that want to use towels intracorporeally, but these draped towels should never be put inside of patients. They're used to drape the field, they're made of a coarser grade of cotton, and they contain dyes. Similarly, some of the distributors now have this natural color, but these are still draped towels. If you have surgeons that want to put towels inside of people, you should have white radio-opaque towels. And this towel has a radio-opaque thread that goes down the seam here. This is a finer grade of cotton, and they're white. And you can see white goes in, has a radio-opaque marker, just like our laps, like our Raytech. We write down on our wall-mounted dry erase board, radio-opaque towels, and we count these in the unit of issue. They come in packs of 4 or 6. We don't put the towels in the holders, and the draped towels we don't count. So at the closing count, this is the time where we take a pause for the gauze, but the most important thing is for the surgeon to perform a methodical wound exam. We've provided a surgeon handout, which the surgeon champion was supposed to distribute to all of the surgeons, that outlines a 3-step process for the surgeon to not just perform a sweep, but to actively look for the sponges. The scrub and circ carry on normal closing count activities, but a good practice is, in this instance, we have 30 lap pads. Here we have 2 holders full of sponges, but I still have some sponges that I need to put in a holder. So before you put a new holder on top, you show your scrub, look, I've got 2 holders, no empty pockets. Then you put the next holder in front of them and continue loading. So in the closing count activity, these sponges are still in use. So we want to limit the areas where sponges are so that it's easier for us to account for them. So now in this instance, we have 30 laps, 20 Raytech. We have 1, 2 holders full of sponges. That's 20. We have 1, 2, 3.
I have
4,
5,
6,
7.
7.
And I believe there's 3 inside.
So there's 3 perhaps inside of the patient. We don't know with certainty because this operation is still going on. We have 20 Raytech. I've got 1 holder full of Raytech. 1, 2, 3, 4, 5, 6.
7, 8, 9, 10, and 10 is 20.
So we would expect that this is a correct closing count. Now the operation is over. They've closed the skin, and we're going to go for our final count. So we have 30 laps and 20 Raytech. So we see we have 20 Raytech. We have 2 holders full of sponges. You could count this if you wanted, but you can see that there are no empty pockets. We expect to find 30 lap pads. We have 3 holders, 1 holder full of sponges, another holder full of sponges, 1, 2, 3, 4, 5, 6, 7, 8.
I have 2.
1, 2. that is not a correct final count because we still have 2 empty pockets in the holders. So even though you have counted the sponges, this is an incorrect final count because the final count must have no empty pockets. A correct final count is when all of the sponges, the used and unused sponges, have been placed in the pockets of the sponge holders. And now you'll see we have 20 Raytec, 30 laps, 4 towels. You have 4 white radiopaque towels. 1, 2, 3, 4. We should have 20 Raytec, 2 holders full of sponges, no empty pockets, 30 lap pads, 3 holders full of sponges, no empty pockets. This is the final count. This, we would say, is correct. All of the sponges have been accounted for. Final count, the last step, is to do what we call the show me step, which is a team-based activity between the surgeon or whomever the surgeon has designated to close and the circulating nurse.
And I want to show you I've got all the sponges. I have 30 laps, all pockets filled, no empty pockets. I have 20 4x4s. All pockets are filled, no empty pockets. All the sponges have been accounted for. Here's 4 radio-opaque towels.
Okay, great. Thanks a lot.
Thank you.
Okay. So one of the most powerful aspects of this practice is now all of the sponges that were used during the operation in one room can't be left in the OR to confound the counts on a subsequent room. So what we do is all of the sponges that were used in one case, because they're contained in the holders, then can be placed now in red biohazard bags or whatever disposal containers your institution requires for the disposition of biohazard material. So it's easy as 1, 2, 3. 3 signs: safety rules, incorrect count checklist, our rack sign, 3 structural elements, 2-prong IV pole, blue-backed hanging sponge holders, and a rack that holds them. Making sure that we account for our sponges. On the in count, the most important are the 3 S's: to see, separate, and say. At the closing count, for the surgeon to do a methodical wound exam. And at the final count, we do a show me step, which is a team-based activity. There should be no empty pockets. Using this practice, we know that all of the sponges have been accounted for, and we can be sure that there's no thing left behind.